Thanks for joining. Let's get started. My name is Dana Finnegan. I'm the Senior Director of Market Strategy at MDaudit. Been here about 10 years. Prior to MDaudit, I spent my entire career on the revenue cycle side, on the provider side. And again, really happy to be with you here today. Who we are, I want to start with this first because we're going to be talking about a lot of data that we see within the MDaudit community. And also, some of you may know, MDaudit recently acquired Streamline Health back in August. And really together, we formed a very powerful partnership to give our clients revenue integrity assurance. And really what that means, folks, is we have a platform, an enterprise-wide platform that can help you not only maximize net revenues, but keep your compliance posture very strong. So we're, again, making sure you're billing compliantly, but really maximizing revenues and reimbursements. Really quickly, we serve over a couple of hundred customers with a nationwide footprint. Even more importantly than that, we've got over 30 years of experience in the ecosystem that you're dealing with every day. We have expertise in revenue cycle, HIM, billing compliance, and much, much more. Lots of awards that we've won in helping our partners. We're going to talk a little bit more about who we are, but it's MDaudit sponsoring this webinar. Really where we want to start is we feel like not only MDaudit, but any technology solution out there that can help you should be really a unified approach. We're not going to go through this whole slide, but really we're going to talk about trends that are going on in the real world, but how technology can help you versus payer scrutiny, less denials, less days in AR, healthier margins, and so on. But really, we're going to concentrate in this area here that says pre-bill. We have solutions that help you with capturing charges, but more importantly, that pre-bill side of it. So before those charges even going out the door, how we can interrogate them and really tell you what needs to be done. So when they do go out to your payers, that you're meeting the highest levels of accuracy and integrity with compliance, but again, what's needed to maximize net revenues. So you'll get this slide to see where MDaudit sits along the entire continuum of revenue cycle, and we're able to help you on the front end, the middle, and the back end. But for today, we're really going to concentrate in that middle piece before that actual claim generation. And you'll hear more about that and how it dovetails into helping you fight the payer scrutiny and other difficult trends we're seeing in your world. So we're going to talk about the 2025 benchmarking report. A little bit about that is how was the report compiled? So again, it's coming from the MDaudit community with 4,500 facilities across the country being utilized by millions of providers and coders, really just spanning a huge footprint. But it's not a survey. We didn't survey a few of our customers. It's hardcore data on denials and audits and external payer audits, all of that stuff that's going on from all of our customers across the country. So the data that we're going to go through is going to be the same type of patterns and other things that you're seeing in your data. We want you to see that you're not alone, but we want to also show you what those insights are so you can bring some of them back to your program, implement them, or at least be aware that they're happening. But it is not a survey. It's from 12 months worth of hardcore data that we're going to expose to you right now. One last thing is we're going to take what's in the benchmark report at a high level. But if you access our benchmark report, it gets very granular. You can literally take a lot of this information if you get our benchmark report back to your revenue cycle, revenue integrity programs. Before we jump in and start talking about revenue integrity redefined in all of the patterns we're seeing with our data is let's talk about how MDaudit is defining revenue integrity in 2026. So I think this visual is very important. What you're seeing here is really a centralized place where revenue cycle and billing compliance and coding and HIM and in the central and professional billing offices Everybody really needs to be sitting at this table, creating a unified front, working from the same data, using the same technology platform that can be deployed enterprise wide. And the reason why I bring this up is it may seem really like a very simple uh, approach, but I've been working with clients across the country now at MDaudit for 10 years, and we still see some of these departments and constituencies siloed. And keep in mind, that's kind of what payers want. Not saying payers are bad or anything like that, but they kind of want you not to be working from the same information because if you're not all sitting at the table working from the same data, um, that can actually give the payers an advantage. So we won't spend too much time here, but we are seeing a positive shift as of opposed to maybe 5 years ago to today, where people are getting at the same table, they're sharing information, everybody along that revenue cycle continuum are working together again to form that united front versus payer scrutiny and payer audits and denials and other things. So you really need to be there. And also at the center of that table, you can see is billing and payments data. Uh, Everybody looking and taking a risk-based approach from that data to then fight that good fight. So again, just make sure at the end of the day, egos are set aside and everybody is working and forming that united front. So let's get into those trends we're seeing. One thing I would mention is the benchmark report does serve all constituencies. So there's information in there for billing compliance. There's information there for HIM and coding. There's information in there for revenue cycle. Today, we're going to really focus on our revenue cycle insights, but the report as a whole has key trends for everybody that I just mentioned. So let's talk about some of those 2025 key trends at a higher level, and we'll dive into these individually. You know it, denials are on the rise. Payers are implementing AI and other sophisticated technologies to double down on the denials. This is driving up days in accounts receivable. It's really driving up cost to collect. And we're going to dive into that more, but denials are really on the rise. In conjunction with those denials is payer audits increasing. So that's when you're receiving those pesky ADRs and you only have a very short time to respond. Those are going through the roof. And we're seeing folks really having a hard time getting the bandwidth to respond to those. So we're going to talk about, how you can optimize your response times back to those requesters through technology so you're retaining more and refunding less. Um, the fourth one over here, let's skip three for a minute, is outpatient coding issues. So in our report, and we're going to talk more about it with some numbers and statistics, but we've seen that on the outpatient side of the world, the coding related denials and scrutiny has really just gone through the roof as well compared to inpatient and pro fee places of service. We're going to talk about why that's happening and what we can do to mitigate that and even come out strong on the other end. And that middle third one is really just, we're going to talk about how technology can unlock some really positive outcomes. I want to say here, I'm not here to sell anything, but I'm here to say that when we do see folks applying the correct pre-bill solutions, denials significantly mitigate, payer audits are mitigated, and coding quality is significantly increased. Really helping pad the bottom line. So we'll talk more about that. But those are some of the key trends from 2025. Now, year over year trends. What this really says is it's a lot of the same categories, but you can see over 3 years, 2023 to 2025, and continuing to 2026, there's certain things that have continued to rise. We don't see a lull in these. We just see a significant trend line going up. So again, coding related denials going through the roof. Really, even the average denied amount, so the dollar amount being denied, particularly for information needed and medical necessity denials, continues to significantly rise. And we're going to talk about what's behind those RFI related denials and med necessity denials. The third one is I think we're all aware of is the average denied amount for Medicare Advantage billing. Medicare Advantage billing has really come into the spotlight and been extremely scrutinized. That's going to continue. So that scrutiny that Medicare Advantage plans are feeling is going to trickle down to you folks on the provider side. And you can see here, we see in our community that average denied amount, dollar amount, really escalating year over year. And finally, the largest trend line that we see, or the steepest trend line that we see, is for payer audits. So those are those ADRs where they're saying, hey, send me these medical records. But at the end of the day, they're looking to do clawbacks. And we need to know how to effectively respond to those. But this is really the picture we see year over year. We have many trends in the report that you'll see, but these are the ones that continually rise and have a very steep incline, unfortunately. But we'll talk about how to mitigate these significantly. So let's go into, again, these are specific revenue cycle insights. Again, we are going to have future webinars for our billing compliance constituencies and our HIM constituencies, but this is really specific to revenue cycle. You folks that are trying to maximize revenues and what's standing in your way from doing that. So the first insight, and again, this is from all of the data from all of our MDaudit clients, is it was clear that the average lag days for payers to respond, just to respond, this doesn't even mean initial adjudication yet, just to get that claim and start to respond to it, has significantly gone up for all care settings. So at the bottom, inpatient, it's gone from 36 days to 39 days, outpatient 34 to 41, and professional a whopping 15 to 24. Now, if you get paid, great. But really what this does is just keeping cash from flowing into your organization. Now, you may say, is there anything I can do about this? I'm at the mercy of the payers. Well, there is. We see folks that are tracking these average days to respond and bringing that to their payer relations teams. So the data is telling you they're taking longer to actually respond to these. That's because they're layering a ton of technology over it to see what they can deny. And they are denying more, as you know. But just from the average days to respond, have your payer relations team sit at the table with payers and see if they're paying according to the contracts, not only in time, but according to the reimbursement you're owed. But for this, please be aware that these days that they're taking, these additional days that they're taking to actually even interact with your submissions, can really hurt the bottom line, because the cash is taking longer to get into your organization. And if they deny, which they are, the rework that needs to go towards those appeals is very costly. Again, going back to the fact that cost to collect is rising, which is really not good for your bottom line. So insight one, taking longer to respond, get your payer relations teams involved and have them make sure payers are adjudicating in the time that they have been asked to based on your contracts with them. Payer relations is taking a huge piece in the organizations in the MDaudit community to make this a better process, better response times. Don't be afraid to sit in the same room as the payers and advocate for yourselves. The second one we talked about Medicare Advantage. Medicare Advantage, just in general, the average denied amount per claim has increased 20%. So not only are they denying more, they're denying more line items, and along with that 20% increase in just overall denial dollars, the RFI denials, the request for additional information, and medical necessity denials have increased 5 times. Little bit more to dig into that, and you'll see it in the benchmark report. I'm not going to go over it all today because we don't have time within the 45 minutes. But if you really drill down, whenever you're billing HCCs to Medicare Advantage, these are being highly scrutinized. A lot of times they may not deny them straight out. You may see a payer audit come in later on down the pike, those ADRs and so on. But when they are denying them, they're primarily for medical necessity and wanting more information. So just know that you need to start doing prospective reviews of those HCCs, make edits in your system of those HCCs so you can attach the appropriate documentation that your different payers are expecting when you're billing out those HCCs. And really other things going to Medicare Advantage. There is technology out there that can let you know what you need to attach and so on to make sure you're having a higher first pass pay rate. We'll talk about that a little bit later on, but just know Medicare Advantage, HCCs, you got to be on top of that and you have to be prepared to understand what Medicare Advantage plans are looking for in documentation support from both a medical necessity standpoint and other information that they're looking for, right related to HCCs. This one I want to spend a little bit more time at. It's coding related denials increased 26% across pro fee and hospital outpatient settings. A little bit more about this. So if we go down to the lower pane here, we can see that coding related denials on the outpatient side went up 23%. On the professional side, 29%. But that 23%, it's huge on the outpatient side between 2024 and 2025. But the previous year, we saw that rate go up 126% on the outpatient side. So when you combine what happened in 2024 and 2025, it's 126% increase and then a 26% increase. So it is really, staggering on what's happening on the outpatient side. Really, what's driving some of that is the adoption of some of the autonomous coding. Now, we're not saying autonomous coding is a bad thing. It is a great thing. But if you're going to implement autonomous coding, there needs to be governance around that. For example, Epic's SVC module. It's a great thing, but have governance and QA wrapped around it. A lot of this is also because it's very hard to retain good coding professionals, those with a lot of years of experience and swagger. It's really hard. Also, a lot of the coding is going offshore. We're not saying offshore is doing a bad job, but all of these scenarios need governance. There are human controls that can be wrapped around that. And there's also AI that can point out, and we're going to show you that today, point out accounts and encounters that really need to be fixed before they go out the door. So after a coder has actually said, I've completed coding, there is technology that we're going to show you at the end that can interrogate those charges and let you know what you need to do to fix them before they go out the door to maximize revenue and be billed compliantly. But what I would say is all of us are trying to look at many different CARCs and RARCs. But when you're looking at coding your categories of denials, coding related denials, particularly on the outpatient side, have really started to surpass things like eligibility and registration and pre-certs. Those were always the categories historically that were at the top of our denial list. You will see that coding related denials have definitely surpassed that. And we need to have governance around it and technology that helps find those needles in the haystack that you can fix before they actually get denied, or you receive a pesky payer audit many months later looking to claw back the decisions that were made by your coding folks. So please vet out your denial categories, and I think you'll see that coding is right at the top. Here's some of the top coding related denials that we're seeing. Again, this is very high level. If you get our benchmark report, you will get a lot more granularity. But some of the ones that I see as a common thread are things like payer deems this information submitted does not support this level of service. That's happening everywhere, professional, outpatient, inpatient. I bring that up because payers are now, and we'll talk about this later on, if you're submitting certain high weight DRGs or certain higher level ED codes, those are being denied right away. And if they're not being denied, they're actually being auto-coded down. They're down coding those just automatically. So I would say that you want to set filters. You want to be able to drill down to your denial population to find anything where they're saying you're not supporting the level of service that you've submitted. Those are huge. We see a huge amount of denials for those and a lot of down coding right out of the gate. And again, we won't spend too much time here. Just wanted you to see some of those different categories. We see a lot of diagnosis related issues, diagnoses not consistent with the actual procedure, modifier and procedure issues. But these are going to be a really good, when I talked about nugget, that you can bring back to your program to see if you're having these same issues. And also, again, we're going to show you how to resolve a lot of this before it goes out the door on a pre-bill basis. We talked about this for Medicare Advantage, but be aware that it's happening across really all care settings for a lot of the payers. Medicare Advantage is absolutely doubling down on RFI and medical necessity denials. But if you look across all care settings, we see 100, especially on the inpatient side, 123% increase in denials for RFI and medical necessity. 28% on the outpatient side and 60% on the professional side. The scary part about being 123% on the inpatient side is there's so much cost and resources associated with treating those patients. The charges are high, the reimbursement is high. So when you send that out and get a denial saying we needed more information, it's not meeting medical necessity, it just again creates that appeal rework, attaching the documentation. You're not getting paid in some cases up to 180 days later, and not to have that revenue coming into the organization can be crippling. So again, we're going to show you at the end how you can employ a pre-bill approach to mitigate a lot of these different denials. So your coding is accurate. So in most cases, they can't come back and say, hey, we're going to deny you for medical necessity. But in some cases, they still will. In that case, again, that's where you need to be doing exercises to understand what are the codes, what are the billing scenarios where I am getting these requests for additional information and setting edits. So you're setting that out on the first submission. But just know across all care settings, we're seeing a huge increase in RFI and med necessity, not just with Medicare Advantage. It's all payers and it's across all care settings. Here's where I want to spend a little bit of time because this is where we see folks really kind of scratching their heads. People know how to work denials. People know how to do appeals. Again, but where they're really struggling is audit requests, external payer audits. Again, ADRs, where they're coming back and requesting medical records, but it's really to do clawbacks. We've seen the total at-risk amount for those payer audits has increased by 30%. It's a massive amount. And what you're seeing really here is at the end of the day, I'll let you, read some of this, but what's happening is you're receiving those ADRs, but there isn't the bandwidth or the technology to respond. A lot of folks are just basically saying, I'm not able to respond. I'm going to write that off. Or I've seen some take the approach that we're only going to go after DRGs, high weight DRGs with a lot of reimbursement. We're not going to respond to payer audits where it may be an E&M or thing like that. We're going to talk later about how if there isn't a response, that could be actually a compliance issue. But what you need to do here is really adopt a technology that can help you respond quickly. We have seen in our MDaudit community, when folks are using technology to optimize response times, they're retaining up to 98% of the at-risk revenue. So 98% of the dollars that are being scrutinized are actually being kept and not refunded. How does that work? Well, now, many of you are familiar with these concepts, but let's talk about it. You need to have a technology like EMDR. What is EMDR? EMDR is when anytime Medicare or one of their contractors sends you an ADR, technology can ingest it and tell you you've received it on the day that they actually send you that ADR. What's happening in the real world for a lot of folks is they're getting those ADRs, but they're falling through the cracks. They're sitting there for 2 weeks because no one knows where they are. Adopt a technology that has EMDR. It'll let you know it got there and you can start working on it in day one. That's on the front end. On the back end, you must have a technology that not only has EMDR, but ESMD. ESMD is the electronic submission of medical documentation. So once you get your medical records together and your appeals documentation, there are softwares and technologies out there where you can hit an easy button and it will take all of that documentation and send it directly back to the requester. Less mailing, less faxing, less stamping. You get an immediate acknowledgement and timestamp that they got it. And in between the EMDR and ESMD, have a technology that can implement what we call automated task management, which is as soon as the system, the technology ingests that ADR, it can automatically send tasks to the people and persons responsible for doing them. So you can get folks that are supposed to supply the medical records in HIM, people from the billing office that need to send appeals documentation, that can all be being done at the same time as soon as that letter is ingested through EMDR. So we won't, I don't want to boil the ocean too much with technology, but just know that technologies like MDaudit and others, they can help you optimize your response time. So when you receive these payer audits, you're not forfeiting revenue or you're not in a chaotic state. Really think about adopting a technology because denials will continue and payer audits will continue, and you need something to respond and put yourself in the driver's seat versus this payer scrutiny. Here's some of the, again, wanted to tease you with a little bit that's in the benchmark report. You can come and get the benchmark report. There's just many, many pages of stuff you're going to need to bring back to your revenue cycle, revenue integrity programs to implement. But here's some of the top codes and other things we see being scrutinized by payers, particularly on the inpatient side. We're all used to sepsis, but then it's followed by cardiac valves, followed by ECMOs and trachs. Again, you'll get this so you can go back and see, am I being scrutinized for this? In most cases, you probably are. And again, you're going to want to reach out to folks that can help you with technology solutions to fight the good fight. But take this information and work it into your programs. Last thing I want to mention before we kind of move on is I found this a really good article, a good read, but kind of a scary article as well. It's from Rack Monitor. But really what they're saying, particularly for Medicare Advantage plans, but everybody's doing it, is when you're billing out certain high risk, high weight DRGs in higher intensity ED codes, ED, E&M codes, payers are automatically down coding them. So what I found interesting about this article was it's not just a revenue leakage issue or a revenue denying issue, but it's a compliance risk. So I suggest that you read this. The link is there because what it's saying is if you're just taking this down coding, you're not only losing revenue, but you're putting yourself at a compliance risk. It specifically mentions the False Claims Act and some related legal risks. So look into that because it was a real eye opener for me. I always knew it was a revenue leakage issue, but it really concerned me when it became kind of a compliance hotspot as well. But again, there are technologies like MDaudit out there that can go through your remits, go through your data, automatically identify what's being downcoded, then allowing you to fight that downcoding through our payer audit workflow that helps you again optimize response times to ADRs and these downcoding issues. Again, technology should be inserted to fight your good fight versus payers. So that, folks, was kind of a high level of what's going on in the revenue cycle world. I'm sure you're seeing some of the same things. If you're not, go back and look at your data. But we want to talk about some 2026 predictions. We see these things continuing, but there is a nice response to it. So denials, they're going to become more complex. They're going to become very clinically related, but they are going to be more preventable. We'll talk about that in a moment. We see denials still going through the roof. Payer audits, we still see that trend line going really way up. That's going to continue to escalate. It's going to require continuous monitoring and technology that can help you optimize your response times. And outpatient coding is really going to determine financial performance. If you can take away anything from here, take away that. We know things are moving from the inpatient only list to the outpatient care setting. We know that hospitals in ASCs, in order to stay financially viable, have to do more on the outpatient side. So those outpatient coding that we see being bombarded with denials, if you hit those and you have the right accuracy rates and you're billing with accuracy and integrity and you have a pre-bill solution that can help you with that, your financial performance will be healthy and successful. And again, you can see in between all that we know technology, when you're using AI and other sophisticated analytics, you're going to be able to really help generate net revenue in this tough system ecosystem and stay with a very strong compliance posture at the same time. Um, this is our benchmark report. There is a code there, so when you get this deck, you can scan that and get our benchmark report to get a lot more information about what I talked today, real granular information. What I'm going to do right now, folks, if you want to stay, and I hope you do, is I'm going to bring up a really, really quick example of a pre-bill solution. This is MDaudit's evaluator. We're going to get through this in about 8 minutes. I don't want you to think about this from an individual case perspective, like an individual claim perspective. I want you to think about what this can do across an enterprise, across billing systems, across EHRs, across specialties, across facilities. What the MDaudit evaluator can do is it can go across all of that landscape and interrogate 100% of your charges before they go out the door at the point of coding. When coding is complete, MDaudit evaluator can run across all of that landscape and literally spit out to you a list of encounters that need to be, let's say, fixed before they go out the door. A little bit about how that works is the engine is AI centric, lots of AI built into it, payer rules built into it, and it's over 7,500 rules that we have based on all different coding guidelines to really, like I said, interrogate those claims and let you know exactly what you need to do. Another nice thing about it is, and we're going to take this encounter, is it can give you a confidence score that says we're 100% confident or we're 95% confident that if you make the changes, in this case 100%, if you make these changes and you do this review, you can gain up to $6,500 additional in reimbursement, in reduced denials, reduced days in AR, cost to collect, all of that. In this case, it's 100% with a $36,000 financial impact of extra revenue. But let's go in and just show you how this works because it is unique. This is way different from traditional scrubbers. This is very, very unique. So I'm going to click on this, and we're not going to go through every machination of this. But what it's doing is saying for this encounter, we're 100% sure that if you review this, you could get up to $6,500 extra in financial impact. And really what it's doing is it's telling me here, and this is something we're very familiar with, sepsis. We just saw on our deck, it's being highly denied, highly scrutinized, and it's a high dollar, clinically difficult, clinically intense thing that's done. So it's saying that the MDaudit evaluator identifies a principal diagnosis code of sepsis without MCCs. So it's first saying, make sure that sepsis is clinically valid. Does it have MCCs and so on? But also letting us know that the secondary diagnosis, the CAUTI, the causal infection, which is a catheter here, should that be reported in the primary position? So it's giving me and saying, take a look at this. It's giving me some of the things to really take a look at. It's even giving me the chapter and verse of where I can go to look up the coding rules. Over here, I even have true code edits. Got a lot of things putting me in the right direction. But to kind of finish this out, you're seeing here that the current DRG is $872. The reimbursement is about $8,600 that we could receive if it's billed out the way it is, if I don't apply those edits that have come up. It's also tracking coder accuracy, which of course is 100% at this point. So what we're going to do is we're going to assume that I've gone in and I've looked at that primary diagnosis of sepsis unspecified and that it is documented that that's what should be billed. But I'm also, as I went into the documentation, seeing this CAUTI for the catheter, I'm realizing that should be in the primary position. So I can very easily take this and put it into the primary position. And now we have that primary diagnosis code appropriate the infection, the CAUTI first, and then the sepsis in the secondary position. Now, if for some reason I needed to go in and say, I want to look at that sepsis, I can go into my encoder here and I could apply maybe it's sepsis due to something else. So I have that available. But as I said, that was the right diagnosis. But I do have that encoder available to me in all the coding guidelines. Now, at this point, I can even go in and track why these things were taking place. I had to resequence the code, or it was an omitted PDX or whatever, but I can track all of this for education. But just by making that small change, I'll now go back and see that the DRG changed from 872 to 698, that the reimbursement that I was going to get when it was as is was 8,600. It's now gone up to over $13,000. My relative weight has significantly increased as well. And I can even go and track my coder accuracy. So there's a lot of good things happening just from having these edits thrown at me. Now, there's other things I can do here. I won't go into too much detail, but I can actually go in and query the physician if I want. I can go in and add comments that I want the coder to see at the encounter level to let them know why I did what I did. Coder can do a rebuttal here. But I more importantly want to then just bring up that advice again, which again, we want you to see this. This is just one rule of 7,500 rules and AI and payer policy built into this engine. Again, as soon as those coders hit code complete, we will interrogate 100% of those charges and let you know if there's something you can fix before it goes out the door. Now, of course, if there isn't anything that's caught through our rules engine, it can go straight to billing. But this will then have that fix made so you can then bill it out. And again, less days in AR, better first pass pay rates, less denials, and up to, in this case, $6,500 more in revenue generation, and that you're billing compliantly. At the end of the day, denials will continue, payer audits will continue, but if you can put a pre-bill solution in the right place, we have seen our clients significantly mitigate those denials, really fight those ADRs and retain more revenue, and just really have a better financial picture in front of them, all at the same time as remaining a great, strong compliance posture. So again, last thing I would mention here before we let you go is this is one encounter. But if you extrapolate this capability across your entire landscape of your healthcare organization, the ability to bill compliantly and maximize more revenues is staggering. And I would also bring up, we have many case studies and many clients that would be willing to talk to you about how they've helped with significantly helping with their bottom lines. I do have a couple of questions that I want to answer because several people have asked really the kind of the same question here. So I'm going to just answer those right now before we let you go, which the first one is, and I should have mentioned this, does this work? Does this pre-bill solution work with any EMR or billing system? The answer is yes. MDaudit's evaluator can work with, Epic, Cerner, IDX, Meditech, Allscripts, all of them. Can work with all of them. Just think of it as being agnostic. The other one, and this was, I think I clarified this, but I'll answer it again. When the charges are interrogated, that is when the coder hits coding complete. And at that point, the engine can run, interrogate them, and let folks know what they need to do. So that's at that point of final coding. And the last thing, yep, this is pretty, and I should mention this. I am sorry. That 7,500 rules and counting, and it will be more in the future. This is going to apply on the inpatient side of the house, the outpatient side of the house, and the pro fee side of the house. So it's not just, I did an inpatient example, but it's going to apply to your inpatient charges, your outpatient charges, and your pro fee charges. So folks, I appreciate your questions. I appreciate your time. Really thank you for your participation today. And again, let us know what we can do in the future because we want to bring you MDaudit again is over 200 customers across the nation, nationwide, as I said, and we want to give what we're seeing in our community back to you so you can operationalize it and have those insights. And maybe someday you'll be part of our community. And we hope that happens.